Grazie, Chiara. Good morning. Opening the... So as a disclosure, I'm medical advisor for Arterys. It was in late 80s that Fluxometry was introduced in MRI using 2D phase contrast sequences. There are cine sequences, that means that they are also ECG gated to cover a cardiac cycle. The principle of these sequences is to evaluate the loss of phase of mobile protons along a bipolar linear magnetic gradient. Thus, we can assess velocity and direction of mobile protons. So it's a one-directional true-plane velocity encoding sequence. It's made orthogonal to the vessel of interest, and it gives two images, one magnitude image and one phase image, phase difference image, which is a velocity map where the static tissue has an intensity of 0 and the moving blood here a positive or a negative value. It was in late 90s that already some teams like Bono Core started to think about putting all that in 3D. And you see here first images of streamlines in the aorta. But it took 1 hour for the acquisition time with very thick slabs, and it took hours, maybe days, for the post-processing. As you can see here, it's a little bit freaking, I'm sorry. But you have a large coverage, as you can see here. You have big vessels, but also smaller vessels that you can assess in 8 minutes, thickness 1.5, and you can do online real-time post-processing now. So how does it work to get this? The 4D flow raw data, one you have down your acquisition, gives 4 different volumes. One magnitude volume and 3 phase difference volumes in the different directions of the space. Once we have this big raw data, we do protection of the health information, and we send all this on the cloud. And as you can see, we do first a pre-processing to correct the phase offsets and the background corrections for static tissue. And this is helped now by deep learning to make this easier. Then we go to the analysis, and we do post-processing with visual flow analysis first, and then we do our measurements. Just a little checklist before we start really doing all that. Of course, we need optimal ECG gating. We have to remember that 4D is 3D plus time. So even when we are scanning a finger or a toe, we need this ECG gating. We have to explain to the patient that the sequence will last 6 to 10 minutes. So the patient won't have a panic attack or be impatient, which can have a problem with the sequence. So we explain everything to the patient, to be patient also. And then we ask him also to have a good and regular breathing. We can do respiratory gating, but most of the new sequences don't need any. We have reliable algorithms that can avoid this respiratory gating. To inject or not to inject gadolinium, this is the question. We can do 4D flow is possible without injection, but contrast media increases signal-to-noise ratio, and we can have larger coverage and shorter acquisition time. As always, when we do some, like an echodoppler assessment of velocity, we have to choose the good velocity and encoding sensitivity to avoid phase wrap artifacts, as here. We can have this flow void as a aliasing or a phase wrap artifact. That's why we will set our Venc 10% higher than the maximum velocity that we expect. These are a couple of parameters that we need and you use. Once you have set them, actually you keep most of them, and you can find it in a paper I will recommend to you later. So the analysis. The step 1 would be the visual analysis of the 4D flow, and the 4D flow offers new tools for that. You have the color velocity 3D MIP here. It's like an echo-Doppler. You have a color coding. Red is the high velocities, blue is low velocities. You can adjust your scale considering the vessel of interest. You have streamlines here. This is the course of a particle would take if released into a velocity field. So you can really see the course of the particle in the blood and where it goes, and it's incredible. And you have velocity vectors. This is also very interesting because you can see the direction of the particle in the blood flow. These different tools actually allow a comprehensive visual analysis of the different blood flows. Here you have a normal laminar flow, which is central. You can have eccentric flows. You have helical flows, which means that particles revolve around an axis. You have also vortical reverse flow, like in this case, which is an aortic regurgitation. It's a real whirlpool. You see here the aortic regurgitation, and here you see the backflow in the aorta, and you see that all these turns are getting thinner and thinner and make a mass at the beginning of the systole, pushing and forcing the systolic flow to go and bump into the aortic wall here. Step 2 is the measurement, the flow measurement. We have to keep in mind that we can retrospectively come in this 3D volume, and anytime, anywhere, we can actually do these measurements and fix our plane optimally, perpendicular and orthogonal to the aorta or any vessel axis. It's cloud computing, so from anywhere, as I said, but also with any device. You can use a laptop, a tablet, even an iPad. And then you access the conventional parameters, which are the forward flow, reverse flow, regurgitation fraction, and peak velocity. You can do quality control and apply mass conservation principle, or compare your data to the stroke volumes of both ventricles. So why using 4D flow versus 2D phase contrast sequences? Because we already have that, and we can assess, for instance, a pulmonary artery, which is not always that easy and might be challenging for technologists to do the right slice. But when we are doing these measurements, it's blinded to what is happening in the vessel. As an example here, we see pulmonary regurgitation in a pulmonary artery which is dilated. So if we do it blindly, we do measure here. But if we turn the data in 3D, we see that we have a vortex here in a dilated pulmonary artery. And this vortical flow can give errors when we do our measurements in this turbulent area here. And we can estimate a moderate pulmonary regurgitation and set it more important and severe. So a combined visual and quantitative analysis is important for a more accurate assessment of this kind of regurgitations. Here are some applications. Of course, congenital heart disease is one of the best, and the more the congenital heart disease is complex, the more 4D flow is important and brings new data. You have a valvular disease we will see with Dr. Paul, and it's in big progress, but also we have a couple of other applications who are appearing every day: aortic disease, pulmonary hypertension, portal hypertension, cerebral aneurysms, and peripheral arterial disease. Here's an example of peripheral arterial disease, but also to show you that this kind of sequence work also with prosthetic material. We will see it later on the heart, but here we have aortic aneurysm, as you can see here. We don't have any compromising artifact, Here we can see all the accelerations, and interestingly we have endoleak here, and you can see the inflow from the lumbar arteries and the outflow from the inferior mesenteric artery, with all these velocity vectors here showing the blood flow direction, and then that can help for a better planning of interventional procedure. We can push things even further and access to flow-derived wall shear stress. The wall shear stress is a tangential viscous shear force per unit of area that is exerted by blood flow to the surface of the vessel. So this wall shear stress can be increased each time that we have an acceleration, and we can see where on the aortic wall or vessel wall we can have this increase of wall stress. Here we have the case of a young patient with a Takayasu disease and hypertension without renal artery stenosis, and here we see that flow acceleration is present in the areas of aortic wall thickening. And when we try to see the effect on the wall shear stress, we see that during systole, in the same area, we have an increase of the wall shear stress. So we can obtain a wall shear stress map. The same patient with a Takayasu disease, here we see that we can explore the heart, but also we can explore other vascular beds, sometimes in the same, within the same sequence, but that means that also we will explore different vessels with high and low velocity blood flows, and that is a risk that some phase wrap artifacts, like here an aliasing, appears because of this very big severe stenosis on this common carotid artery here. So we cannot measure the flow, which is the area under the curve. So one of the solutions for that is to do multi-Venc sequences. Here is an example of a prototype of dual Venc sequence with a time of scanning which is 1.5 longer than the single one. We can explore the low velocities vessels and the high velocity vessels together simultaneously, which is incredible. It's also the power of cloud computing, because we can do simultaneously an analysis of two very big data sets. And this is the result in a patient operated with a sending repair for transposition of great vessels. We can assess accurately the low velocities from IVC and SVC connections, but also the high velocities of the big vessels, great vessels. So FortiFlow is ready to go now. It's a revolutionary new tool in CMR, enabling optimal flow measurements, a new comprehensive approach by visualizing blood flows. FortiFlow enters the field of clinical applications right now. With congenital heart disease, now it's kind of routine now. And with valvular heart disease, we are going to see for both with my colleagues that it's in big progress. But also widespread of new applications are appearing every day. Cloud computing enables real-time processing of big data anytime, anywhere, with any device. And also, as Chiara said before, sharing easily data with colleagues, also for question, expertise, education, or multicentric trial. Deep learning saves time for analysis. In one hand, by helping faster correction of the phase offsets error, but also by providing automatized LV and RV stroke volumes to compare our data. And finally, dual Venc sequences, when needed, enables good assessment of low and high blood velocities within the same sequence. Thank you very much. You can find these pictures, movies, tables, and more in the this paper appearing just right now in Radiographics. Thank you very much.